Fortunate today to have Chris Craig with us. He's a PA at Wake Forest Burn Center, where he's been for lots of years, about 16 years or so. Also holds the position of assistant professor of surgery. So he's had his undergraduate degree at Davidson, so he's been close by for a good while, and then did the PA program at Wake Forest, and then subsequent further graduate work at the University of Lynchburg. He's very experienced in the first responder world, both in sort of locally North Mac in the Huntersville area. He's worked with the Department of Homeland Security, the Coast Guard, and lots of other entities. He's one of the few ABLS, that's the burn program instructors in North Carolina, and so that's going to be the topic of his talk today. So, Chris, looking forward to your expertise. Thanks for persisting through technical difficulties, and we'll turn it over to you.
Yeah, thank you so much, and very, very nice introduction. I'm humbled by it. But I also teach at High Point University, hence the High Point University title slide here. So I have a dual role with that. So education is kind of my wheelhouse at this stage, and so we wanted to be able to impart some of that knowledge on all of you guys, specifically with the topic of burn resuscitation and really what makes resuscitation so important to our burn patients. It's a little bit different than in the trauma world, where we can do 2 large bore IVs and open fluids wide open or give boluses. We have a little bit more of a nuanced approach with our burn folks. And so that's really going to be the focus of the lecture today. To do that, we have to have a little bit of a background and understanding of the different types of burns that we can experience and different depths of burns. So it's also a little bit of a burn overview. And I will kind of rush a little bit through the burn overview piece just so we can get into the bread and butter of the resuscitation piece, which is the purpose of the lecture. But basically, by the time we finish, I want everybody to kind of understand how the host or how the patient is responding to these burns, and really know what our end goal for the resuscitation is. We'll learn how to calculate initial fluid rates and adjusted fluid rates. Things have changed a little bit in the last few years, where the American Burn Association is now recommending an initial fluid rate that is just a static delivery of fluid, and then getting into what we used to all be used to with Parkland formula and more of a consensus formula to have an adjusted fluid rate for the first 24 hours of care. Then we'll talk about how we really need to titrate these fluids during resuscitation in response to how that host or patient is responding to the fluid administration, and then talk about a few complications of fluid resuscitation in burns in special populations. And so kind of getting started, we'll talk about how the host responds to burns, a little bit of epidemiology and etiology. But the big thing that we really calculate at the national level is that when we look at all burns that occur, greater than 90% of burn injuries are preventable. And I would argue 100% are preventable. The ones that fit in the national category of non-preventable are things like house fires or an electrical panel in the wall sparking and causing a house fire, an apartment fire. Well, that's preventable, right? I mean, if you have a good electrician or you take care of construction in a proper way and don't have a staple through a wire or something of that nature, that too is preventable. But they categorize that as accidental. When we look at the number of burns really throughout the country, there's an estimated 1.1 million burns a year that require some sort of medical treatment. And that may be through a primary care provider, an urgent care, something of that nature, all the way up to about 45,000 of those requiring true hospitalization. And that's going to be at least one midnight in the hospital. So it's not a trip to the ED, it's actually spending the night in the hospital for at least one day. And then we kind of break down where we are today as compared to where we come from. So, last year we had about 4,500 deaths that were related to burns throughout the country. And when we compare that to the 1970s, we were looking at about 15,000 deaths per year. And so we've come a long way with regard to ventilator management, critical care, antibiotics, how quickly we graft people, different modalities that we have for getting wound closure. So we have a lot more survivability now than we did, a mere 50 years ago. And we can see that also with the LD50. So the LD50 is the lethal dose that 50% of people will die if they have this size of a burn. And so these days, that 50% mark is right at about 70% total body surface area, and that's across all age groups. And compared to the 1970s, a 30% burn would have been your LD50, where you had a 50-50 shot of making it. And if you really think about a 30% burn, I mean, that's basically kind of anterior torso. I mean, when you break things down into rules of 9, 18% and 18%. So if you look at the torso alone, you'd be at that 30% mark automatically. What's really remarkable is about 50% or greater of our patients are returning to pre-burn function. So it's not just that they're surviving, but they're actually surviving and able to recontribute to society in the same way that they were able to prior to their burn occurring. And so that really is held true to our multidisciplinary approach, where it's not just the surgery group, it's also the nursing group, the PT and OT group, chaplaincy, nutrition, rehab, all of these folks coming together and playing nice in the sandbox. So we'll kind of fly through these a little bit, just kind of give you a peek at the different types of burn injury that we might have. With an electrical injury, we pay attention to whether it's AC or DC. We want to know if that electrical current is grabbing onto you or kind of throwing you off. And then we split things into high voltage versus low voltage. High voltage is going to be commercial, industrial lines, like the actual high tension power lines, anything over right at about 1,000 volts. And then when we look at low voltage, it's anything less than 1,000 volts. And 1,000 volts is actually a fair amount if you think about what runs through your house, right? Once you're on the house side of your panel, you're talking about 220 and 110 kind of going through the walls. And when you get back to the pole, you're actually still relatively low. It's once you get to more of the high tension power lines that you'll see 1,000 volts, or in some cases commercial settings where they just have a really big leg coming directly into the skyscraper, for instance. When we have electrical injury, basically the tissue death is because the electrical energy is being converted into thermal energy. And as it goes through the different connective tissue that we have in our body, there's different resistance of each of those conducting tissues. So for instance, bone is going to heat up a lot more than, say, skin might, because of the fluid that is in the skin or in the muscle. The other problem that we have is nerves are made to conduct. They're just very small gauged wires that go through our body. And so you can actually blow those smaller gauged wires with a higher level of energy, higher voltage. And so we end up with a lot of neuropathic pain and neurogenic symptoms. There's also a phenomenon of arcing, which is basically the superheating of the environment surrounding a person, but they did not actually get electrocuted or have an electrical injury. They're actually a thermal burn from the environment sort of turning into a plasma arc because of the huge amounts of energy coming from the electricity. And sometimes that will cause ignition of clothing. And then we also have associated injuries, like the person falling out of the bucket truck or falling off the ladder, or being blasted back from a panel and striking the wall behind them. So again, the severity of the injury is going to pretty much be proportionate with the voltage. So the higher the voltage, the more the severity. We call it the grand masquerader because you may have a very small injury that you can see, but the extent of the true injury is much, much greater than what you can visually appreciate. And so this picture here is a gentleman that was working with electricity, and you can see that contact point that's right there in the midfoot. And he had sort of a energy blowout through the toes with the latter three smaller toes. And he also had a very small contact point near where his wedding band was. So it was a very small appearing burn wound on the hand. This gentleman actually died after about a week in the hospital from renal failure, cardiac failure, hepatic failure. So the energy that went through his body actually caused multi-system organ failure, even though what was visually appreciated on the outside was not too terrible. You can also notice barely his great toe is a little bit elevated. That is actually a fracture that occurred from the energy of that electricity. So he had a foot fracture, and the metatarsal was broken just behind that first joint of the great toe. The phenomenon of arcing is one that is also sort of difficult to appreciate until you get someone unclothed in the trauma bay. This gentleman here was a lineman, and he was working with the proper personal protective equipment, and an arc surrounded him. And his clothing actually looked completely unscathed. And the actual thermal energy that was around his jacket superheated and caused the burns that you see here. And these are actually pretty deep, pretty severe burns. You may be able to notice on your screen that he required escharotomies on his bilateral upper extremities, and that was due to full thickness injury to both arms. And then he's clearly got some full thickness injury across the back as well. And this was basically just due to ionization of the atmospheric air that was surrounding him, which generates temperatures up to 4,000 degrees Fahrenheit. So even though his clothing did not physically burn, it heated up so quickly that it burned his skin beneath all of that. In arcing, you don't have to worry about electrical contact. You just treat it just like any other standard burn. When we get into chemicals, basically chemicals, there's a ton of them throughout the country, and many of them are considered hazardous, but we can absorb that through our skin. If it's spilled onto us, we can ingest it if we drink it. Obviously, if it's turned into a gas, we can inhale it. There's also injection. If you think about in the clinical world, we have different medications that we give, chemotherapy, propofol, you name it. If we have an infiltrated line, will actually cause a chemical burn to the surrounding tissue. So injection should definitely be on that list as well. And then you can have any combination thereof. So it may be that chemicals got on your skin. They were also off-gassing, so you inhaled it. And so you may have a combination injury as well. We keep things pretty simple. We just split things into acid versus base. So acids, very common ones, are listed here, and then common bases are listed on the right. The big one I'll point out here is the methamphetamine manufacturing, because not only do you have the base from Red Devil Lye that's included in sort of the cooking process, but you can also have thermal injury from explosions that may occur within that methamphetamine manufacturing world. So sometimes your chemical burns will be mixed with thermal burns as well. Whenever we have an acid burn, it goes through a process called coagulation necrosis, which is the same process as how we make leather. So it's tanning a hide. You're placing acid in contact with animal fat and animal tissue, and that creates a tanned hide. So you literally are causing leather on a patient. Bases, on the other hand, they actually will denaturize their proteins and go through a process called liquefaction necrosis. And that basically eats deeper and deeper and deeper. So it allows that chemical to spread deeper into the skin, and it will cause a further progression of the burn. And this is the same process that we use to make soap. So when you have a bar of soap in your bathroom, it's basically animal fat mixed with a base, usually lye. And that's what makes soap. So we'll make soap on our arm with a chemical burn. The big, most important thing is you want to remove their clothing. As a initial decontamination measure. If you think about the amount of clothing that most people wear, taking their clothing off will automatically decontaminate them about 80% because of how much that clothing is covering of their body. And certainly some of those chemicals, if liquid, can get through their clothing. So you still want to decontaminate them with copious amounts of water. But we have to make sure that that is not contraindicated. So for instance, if they had lithium or sodium or potassium as a chemical nature, as a powder on them, if you add water, it explodes. So you have to make sure that you know what the chemical is before you just jump right into putting water on them. If you have decontaminated them with water, you obviously have to avoid hypothermia. And obviously, to protect ourselves, we want to make sure that we have the correct personal protective equipment for us. Thermal burns are basically the bread and butter of burn care. We do this day in and day out. By far, it's a majority of the burns that we see. And our burn injury severity, so the depth of the burn, it's going to be based on the temperature of what you came in contact with, how long you were in contact with it, the thickness of the dermis, and that's both going to be age. So our elderly and our super young have much thinner dermis than someone of middle age, but it's also the location on the body. So the palms of your hands, your face are much thinner than, say, on your back, which has a much thicker dermis. So you'd probably have more severe burns in the thinner areas of your body, or you will have more severe burns if you're elderly or super young. Blood supply is also an issue. So if you have peripheral vascular disease, if you've got a previous arterial occlusion, diabetes, things of that nature, obviously you're going to have a much more severe burn where you are already fragile. So when we talk about burn depth, obviously a first-degree burn on the far left here, that is only involving the epidermis. So the epidermis is the very outer layer of our skin, and it is a burn that does not go down into the dermal elements of our skin. And so it's basically like sunburn, which we'll see here in a little bit. When we actually have fluid-filled blisters, that's going to be a second-degree burn or partial thickness burn. And those partial thickness burns can be split into two different categories. You can have a superficial second-degree burn or superficial partial thickness burn, and that's just barely getting into the dermis. You're not getting down into that reticular dermis that's deeper. You're sort of staying in that more shallow area. A deep second-degree burn is going to go a little bit deeper where some of the subdermal plexus and subdermal appendages are, like your sweat glands, your hair follicles, nerve endings, things of that nature. And so there's damage there, but you hopefully have enough dermis left over to be able to reproduce epidermis on your own. But every once in a while, your deep partial thickness injuries are going to require skin grafting, just like a full thickness injury would. Next to last on the right, you can see a full thickness injury where there's actually white chalky eschar where everything is desiccated. You've burned all the way down to the layer of the fat, and you have certainly damaged all of the subdermal structures. And in this case, you don't have any ingredients to make new epidermis, and you don't really have ingredients to make new dermis. And so these are the cases that absolutely require skin grafting for you to heal. There's no other way for you to get that wound to close. And then a fourth degree burn, some people use that nomenclature, some don't, but that's when you get down into muscle, tendon, and bone. At Wake Forest, we just call that a wicked third degree. We don't really term things fourth degree in our center, but it would just be a really, really deep third degree burn for us. We'd just consider it full thickness is full thickness. So from a visual standpoint, again, first degree is essentially sunburn. It's pink and painful. It doesn't blister, and it will heal on its own. When we get into more moist blister forming injury, that's going to be our second degree burns. exquisitely painful because we're down to that layer where those nerve endings are. And usually that'll heal without excision and grafting within about 3 weeks. And if it does not heal at that 3-week mark, then it's likely that we were in that deep partial thickness realm and it just didn't have the ingredients to make new epidermis, and we may have to help it with a little bit of surgical management. Full thickness is dry and leathery. It's usually insensate because we've burned all the way through the nerve. Those that say that their 3rd-degree burns are hurting is usually because of the border that is surrounding the 3rd-degree burn, not the 3rd-degree burn itself. And this absolutely will require excision and grafting, or it just won't heal. And so anytime we have an injury, we're looking at 3 different zones. The zone in the middle where you can see that sort of petechial splatter paint pattern of red, that is called the zone of coagulation. And that's where the vessels have actually coagulated and that tissue is dead. It's not coming back. That will require surgery. The zone of stasis that surrounds that is sort of sitting on the fence trying to decide if it wants to heal or if it wants to die. And that zone of stasis is what we are actually attacking when it comes to our resuscitation. We're trying to not starve the zone of stasis and have it die, but we also don't want to flood the zone of stasis and have it die. We have to give it the perfect amount of fluid so that it will go towards healing and not go towards coagulation. And then just surrounding that area is the zone of hyperemia, which just is a fancy word for lots of blood flow. And that zone of hyperemia is also important because that is why we're getting so much of the fluid that we give people down to that zone of stasis. So they're very they've got open capillary beds. They're sort of third spacing some fluid in that area, which is why we get massive amounts of edema. But it also has all the healing mediators rushing to that area due to the insult to the skin. And so what we want is that zone of stasis to survive and become more of a zone of hyperemia without flooding it out or starving it to be more like the zone of coagulation. We also have to know how big the wound is, and that's going to be very important for our end goal of resuscitation. We can do that with different modalities. One is the Palmer method. You can see on the far right, basically the patient's hand in a closed fashion, just like it is pictured here, equals 1% of their body. So you can estimate 1, 2, 3, 4, 5, 6, you're about 7% burned based on their palm of their hand. This works very well for odd distributions. It works well for very small wounds, and it works well for your super big wounds. And the reason I say for your super big wounds is you can use it in reverse and count the good skin with the 1% and then subtract that from 100 and you go, wow, you're 98% burned because I only have 2 palms worth of good skin left. The rule of 9s is a little bit more specific, but it does require some memory and some training. You can see that your infants compared to your young children, compared to your adults, their percentages are slightly off. And that's because the younger you are, the bigger your head is and the smaller your limbs are. So your babies have big old heads and little tiny legs. And so they end up with a different distribution of their rule of 9s. Once you get to an adult, this is truly rules of 9. So the front of, this is front and back that you're seeing here. So the front of the face is about 4.5, back of the head is 4.5. Your anterior torso is about 18, posterior torso is about 18. So that adds up to your 3.6. Each arm is 9, each leg is 18. And then because that all adds up to 99, 1% goes to the genitals and perineum. The London Browder's chart, which is on the far left here, that is usually used in burn centers or once you've reached some amount of definitive care. and it is much more nuanced, but does require a lot more training to be able to get an accurate picture of the total body surface area. But it does give us a much more accurate read, and so we can be much more specific in our treatment plans, rehab plans, and certainly, as we're talking about here, in our resuscitation plan. So again, the burn size estimation, rule of nines, it can often overestimate, but it is faster than London Browder. And the reason I bring that up is most of our pre-hospital providers are taught the rule of nines, and that's sort of where it lands. And they don't use it all the time. And so we end up with overestimations of the total body surface area. And then inevitably, we have an incorrect guess on the patient's weight. And so even if they have remembered the rule of nines very well, or remembered the Parkland formula really well, they still end up with incorrectly calculated resuscitation measures because of their overestimation of the burn or over or under measurement of the patient's weight based on guessing. So rule of nines is not perfect. And instead of changing the rule of nines, we've actually changed the initial versus calculated fluid rates, which we'll talk about in a few slides here. So as far as the end goal of resuscitation, this is sort of why we do what we do. Again, if you remember that slide about the zone of stasis, this is why that zone is so important. So when we have a burn injury, we end up with this massive inflammatory response. We end up with a lot of evaporative loss from the destruction of that epidermal layer and dermal damage. We're no longer protected within our shell of skin. And we end up with a progressive volume depletion, which is usually because of capillary permeability increasing. So the capillaries are trying to feed the damaged skin, so they open up and allow third spacing to occur. That gives you a relative hypovolemia, which then leads to decreased organ perfusion and organ failure, which by definition is shock. And so if you have this unabated shock, then you will end up dying from it. And so what we have to do is figure out how to counteract that progressive volume depletion in a way that can counteract the increased capillary permeability so that we don't go into shock and we don't die. And so one of the ways we do that, if you look at sort of a normal blood capillary, we've got water that can spill in and out, but usually the actual blood products that are made of protein are not spilling out. But when we have this increased capillary permeability, it opens up where the proteins are spilling out as well. And so we may choose LR, which is it more closely mimics the intravascular fluid, but it has larger Dalton molecules in it that are less likely to spill out through that capillary permeability. If we do have a continued spilling of the intravascular fluid because of that permeability, then sometimes we in the burn center will switch over to more of a colloid rescue than we do the crystalloid resuscitation. And we'll use albumin or we'll use fresh frozen plasma, which has a much larger Dalton size protein and does not spill out in the same manner. But that's not really anything we do pre-hospital on a regular basis or anything that we prescribe for outside hospitals. That's really more just for you to have in the back of your mind. So the real thing that we're trying to overcome is when we have a burn, we have an increased peripheral vascular resistance, which is going to lead to a decreased cardiac output. And that progressive hypovolemia compounded by basically a distributive shock will then lead to tissue damage down the road. And so we're trying to counteract that by giving an adequate resuscitation. An adequate resuscitation does restore the cardiac output. It helps us with our tissue blood flow. It prevents organ failure. And then it's really obviously critical to survival because we're not drowning in our third spaced fluid. Fluid replacement really needs to be sustained over time because we're leaking over time. So if we give boluses, I've given you sort of a slam dunk a huge amount of fluid, but then I'm losing it slowly over time. And what I want is to give it to you at the same rate that you're losing it, which has got to be a guess because it's sort of this uncalculable amount that we're third spacing. And so we were basically trying to maintain that tissue perfusion and organ function while not giving too little or not giving too much fluid. We're trying to get that Goldilocks approach where we get exactly the right amount. Excessive resuscitation is more common than insufficient fluids because people usually feel like they need to give more and more and more when somebody's not responding. But that'll actually lead to more of an exaggerated edema formation, which can then lead to morbidity of the extremity or abdominal compartment syndromes. And usually if you have an abdominal compartment syndrome bad enough to cause intra-abdominal organ damage, it becomes a non-survivable issue. You just can't get Humpty Dumpty back together again. It can also lead to lung or cerebral edema just because of how we third space in those areas. And then obviously patients that are super young or super old or have pre-existing heart conditions are going to be the most sensitive to excessive fluids because they can't handle that additional fluid being given to them. This is super important for the first 24 hours because our maximum edema is after that 24-hour post-burn injury. And if we've preloaded them with all of these all these fluids, then they end up sort of falling off the curve at the very end. On the flip side, insufficient fluid resuscitation will cause a hypovolemic shock, and so we end up with multiple organ dysfunction and failure. And so we really have to make sure that we increase our increase our fluid administration due to that increased capillary leak and higher fluid requirement. And that really needs to be initiated as soon as possible. And so that is where we get into all the fancy math that we have to use. Again, fluid of choice is lactated ringers because it mimics the intravascular fluid. But if you only have normal saline, that's certainly better than no fluid at all. And then if you're thinking that you need colloid and have access to it in an outside hospital, we would just encourage you to have a conversation with the burn center for your area prior to initiating that colloid, because there may be some other things that need to take place prior to just flooding them with more and more and more fluid. So this is where we get into all the fancy math, advanced geometric trigocalculus. But it should not be super, super complicated. We've got a myriad of people that have done lots of studies on how to give the right amount of fluid. Brooke, Parkland are probably the two most common. Parkland formula being what's in most textbooks, and Brooke being what was really used in most hospitals, or a modified Brooke at least. Well, we've actually studied this for a long, long time. Some of the first studies that came out were in the 1940s surrounding the World War. We had a lot of data that came out of the Korea conflict, and then we had a lot of data that came out of Vietnam. And then we have started studying things a little bit more in the scientific realm, stateside ever since then. When you look at Greenhall's summary of international practicing burn surgeons, we see that a lot use LR and albumin or FFP. So there's a combination of colloid and crystalloid. But you can just see based on these numbers that the sad thing is there's always disagreement. So if you put 10 burn surgeons in a room together, ask them one single question, you'd get 15 answers. And that's just because we can't even agree with ourselves sometimes. So the actual ABA, the American Burn Association, said because we're overestimating our TBSA, we're screwing up how we calculate our kilograms, nobody can agree on a formula to begin with, and it gets complicated to remember the formula if you don't use it all the time, then we're just going to make a pre-hospital and early hospital setting initial fluid rate. So if you are under the age of 5, you get 125 an hour. If you are between the ages of 6 and 13, then you get 250 an hour. And if you're over the age of 14, you get 500 an hour. And this is for any burn that clearly exceeds 20% total body surface area. So we've basically worked out that you're going to be ballpark somewhere close to these initial fluid rates after we've actually done a formal calculation. So we might as well just start you on something easy. And so we just do the math as 125, 250, and 500. When we do an adjusted fluid rate, we're actually using the rule of nines and figuring out the patient's weight, and then we're using a formal formula. And so that formal formula here, if it's a flame or scald burn in an adult, is simply 2 cc's per kilogram per percent total body surface area. And this is what's in most textbooks around the country. Children, we bump them up a little bit because, again, we know that they're a little bit more sensitive to fluid, and we want to make sure that they don't sort of fall off the cliff from a decompensation issue. So they get 3 cc's per kilogram per percent total body surface area. Infants and young children, they actually need their fluid resuscitation plus a D5LR at a maintenance rate because they are not able to produce the same amount of intrinsic glucose through their livers. And with the glycogen stores being so low, they sort of run out of sugar and run out of fuel very quickly. So we have to give that to them extrinsically. And then our electrical injuries, which we remember are great masqueraders because of the internal damage that we're not necessarily aware of, and the fact that muscles are highly affected by electricity. We increase that fluid to 4 cc's per kilogram per percent total body surface area to try to flush out some of the toxins that are from dead muscle, or rhabdomyolysis and things like that. Now, when you get to an actual hospital, either an outside hospital that has a protocol or the burn center, we do things even more differently. So we will calculate that initial fluid rate based on the 125, 250, 500. Then we do our adjusted fluid rate, which is going to give us a number in the yellow box there to say this is what we're going to start them at. But then we have a nurse-driven protocol that says if we have a decrease in urine, then you're going to change by this protocol. And if you're above this urine output, you change in one way. If you're below this urine output, you change in another way. But because that is nurse-driven, it gives us the ability to make adjustments every 1 to 2 hours. Our kids are a little bit different as well in the burn center because we actually not only do LR and the maintenance of D5LR, but we actually give them FFP as well to have some of that colloid in the system to keep some of that capillary leak at bay. And again, the reason we're doing that is to save that zone of stasis. That zone of stasis is not just going outward from the zone of coagulation, but it's also going deeper from the zone of coagulation. It's in all directions. And so if we do not preserve that zone of stasis, we end up with a much, much bigger, wider, but also deeper wound, and that's going to give them a requirement for a much harder surgery to survive. And in some cases, it means that they're not going to heal on their own. You can see in the bottom, these two squares, the one on the left had the zone of stasis preserved, and it will heal on its own because it's still within that dermal range, where the zone of stasis was lost on the right. And that's gone both wider and deeper, and that deeper nature is now full thickness, and so it's going to require surgical management. So for us to get that Goldilocks approach and have just the right amount, we have to titrate, and we can't do that the way we do in trauma. We have to make sure that we're looking at different vital signs. So we start with our initial fluid rate titration. Again, that's going to be the traditional Parkland formula looking at the first half of the calculated formula in the first 8 hours, and then the remainder of that over the next 16 hours. And so that means that we're giving a majority of it up front, but then trickling off as the 24 hours gets closer. And then we really find it critical that we look at an hourly titration of fluid. Otherwise, we may flood them over time or starve them over time. So the reason, the way we do this is through urine output. And so in an adult, you want 0.5 mils per kg per hour of urine, which is going to calculate out to about 30 to 50 cc's an hour. And then in kids, it's going to be twice that much. So you want 1 cc per kilogram per hour for children. And really, if you think about how much a kid weighs, by the time they're 14, they should have exceeded sort of that 30 to 50 kilogram weight. And so 1 cc per kilogram would be 30 to 50 cc's. Does that make sense? So your bigger kids are going to end up kind of converting themselves into an adult realm. So if you had a 13-year-old that just happened to be heavy set, you certainly can run them at an adult titration rate. You really should be measuring this with an indwelling bladder catheter and then incrementally increasing or decreasing your fluids based on the urine output. So if you have too much urine, you back off your fluids by 1/3. And if you have not enough urine, then you want to increase your fluids by 1/3. But you're basically going to titrate up or down to try to have that Goldilocks approach. And so the reason we use urine is because blood pressure monitoring may be misleading in our burned limbs. We can't get a good auditory signal, so we're not going to necessarily know that the blood pressure is accurate. And then if we have an intra-arterial monitoring that should be the most accurate, we do have vasoconstriction with our decreased peripheral vascular resistance. Increased peripheral vascular resistance, and that can be led by vasoconstriction. And so we end up with an inaccurate guide for our fluid. Heart rate, that can be hard to monitor with because tachycardia is very common in our burn patients. It may be related to pain. It may be related to drug use. There's all kinds of physiologic reasons that tachycardia may exist other than just being low on fluids. Usually if it's a severe tachycardia, so something over like 140 beats per minute in adults, then that is related to hypovolemia. But there are other levels that may just be considered normal. And then anuria is very difficult because if you run out of urine, if you've got an acute injury to your kidneys, then you're just not going to be able to track that urine output. But we do not give diuretics because it's going to give us a false reading. So complication resuscitation, basically, if you have an associated trauma, these patients are not going to behave very well, and you actually may need to bolus them. That would be if they have internal bleeding, if they've got blood loss that requires boluses of fluid to maintain their blood pressure, or true blood products, you treat them as a trauma first. So they are a trauma that happens to have a burn, not a burn patient that happens to have a trauma. If they have an inhalation injury, we have a difficulty accounting for that injury. We don't know how much fluid is required to keep those lungs at bay. And we actually see that it doubles their mortality, twice as likely to die, but they will also have complicated resuscitations. Electrical injuries, again, grand masqueraders, so we don't know how bad the injury is, so we don't really know how much fluid to give them. And so we have to sort of play a guessing game. And then extremes of age. The super old and the super young, they just plain don't behave. So you can do everything perfectly and they're just going to fall off the cliff from a compensation standpoint. If there's a delayed resuscitation, so either a patient was found down after a long period of time, or they were at an outside hospital or a long transport and did not have the right calculations done, then it can become a problem. And then medical comorbidities like drug use, alcohol abuse, things of that nature, they'll always complicate everything. Super deep burns, just because the skin doesn't react very well. And then if you have inadequate escharotomies or compartment syndrome, they too will be highly complicated. And this is for Scott because he keeps texting me. Oh, I got 37 more slides to go. I'm kidding. We're done. But these are some references. If you guys want to look up anything on your own, I will put in a selfish plug that if you guys want a formal advanced burn life support course for either your hospital or pre-hospital setting, just get up with Scott Wilson. He can get you in touch with me. Every once in a while, we're able to find grants at the state level to kind of bring that to you cheap or free. Otherwise, there is a cost associated with it that's set by the American Burn Association, but I'm happy to work with you guys on formal education. And then I'll be always happy to give these little talks like this just to give you a teaser and a taster. Any questions for me? Otherwise, I'll let you guys get back to your days.
Well, that was great, and that's more than just a teaser. It's pretty thorough as far as damages that burns can cause, and I think it's useful for everybody on the call. So I'll open it up to the crowd. Who's got some questions for Chris today?
I either put them to sleep or I answered their questions preemptively.
Scott's still with us. Looks like he's got his hand up.
Great talk. Thank you. In the initial phases of care, when things may be a bit more chaotic, do you find that fluid management maybe get to be a little bit too much? If too much fluid was administered beyond what Parkland recommends, can we come back from it? Thank you.
Yeah, so yes, you can come back from it in the sense that if you are physiologically responding to your over resuscitation and we get you back to the correct numbers, then you will have a period of higher urine output. Your body will try to correct for that. The issue really comes in when you're critically ill, super large burn, or you already have chronic kidney disease, or you have an acute kidney injury, concomitant trauma, any of those complications that we talked about on slide 44, those folks don't recover as well. So you have given them too much fluid and they're going to hold on to too much fluid. And then you play this weird game because if you say, well, they've gotten 2 liters more than they were supposed to get, so I guess I'll withhold 2 liters from them. You can't do that. They've already third spaced the additional 2 liters, so now I'm starving them of what they need. So you really just have to get them to a good calculated Parkland or modified Parkland formula calculation as soon as possible and be accurate with it, so that you are minimizing any damage from either starving them ahead of time or flooding them ahead of time, because you can't ever really get that fluid back unless they're healthy. And in 16 years, there's probably a handful of people that came into my burn ICU that were previously healthy. I think that's the case for really any critical care setting. That your marathon runners that can handle a burn of that size are not the ones getting burned. So it becomes a huge issue if you've over or under resuscitated ahead of time.
Is there a good rule that you could give for pre-hospital, or maybe nursing or providers that are out in small rural areas where you're going to have, let's say, an hour plus transfer to somewhere? I love that you're speaking toward the accuracy of calculations and resuscitation, but if you've just got to make a quick guess and get things moving, how would you counsel people to say, look, get this going and get that patient out of there? I know it's going to be an hour plus till they get there, but what's the safest way to approach that?
Sure. So the American Burn Association answer is that 125, 250, or 500. That seems to work pretty well when you're talking about 1 to 2 hours, maybe getting into 3 to 4 hours, but certainly in your 1 to 2 hour range, because you're pretty darn close when you do any iteration of math for those folks. Where that becomes a huge issue would be your sort of extremes of injury, and those people sort of have a lower chance of survival anyway. So if you were a 90% burn and you only ran them at 500, and I say, well, you should have been running them at 800, they're probably going to die because it's a 90% burn, not because they were 300 shy on fluid. So I just tell people, keep it simple. If you're in the pre-hospital setting, running a truck, ambulance, helicopter, plane, whatever, just do your 125, 250, 500. You can't go wrong with that. If you're in an outside hospital and you're looking to transfer to a burn center, have a conversation with the burn center. I mean, literally, we're a phone call away. You're in a reasonable setting that phone call should only take a few minutes. But whoever's in your catchment area, so like Charlotte area would be like Wake Forest. If you were out at the coast, you'd be talking about UNC. But if you know who your burn center is, your referral burn center is, you just give them a call. Say, hey, I've been running this guy at 500. It's going to take me a couple hours to get him to you. I'm pretty sure I did the math right, that he's about 74%, and I'm guessing he's about 80 kilos. What do you want me to do? And they may say, let's do the math really quick. What's 2 times 80 times 76? Let's divide that by 16. Let's give him that amount of fluid. And then you've sort of passed the buck a little bit, right? You've had the subject matter expert give you the advice, and you haven't winged it. So it's kind of like I tell my kids, if you come to me first, we're going to be all right. But if you try to hide that you did something and I find out about it later, we're going to have words. Well, it's the same with burn resuscitation, right? If you call me and I give you some wrong information, that's on me. Like I told you what to run it at. But if I just have you send me a patient and you show up and go, well, I was pretty sure, 9 liters an hour was right. Well, you just killed somebody. So just make the phone call.
Great way to put it. Thank you. Other questions from participants? Got a pretty good crowd on. All right.
Awesome. Thank you so much. I really appreciate the opportunity and look forward to anything else you guys might want out of us. More than happy to join in, and Scott knows how to reach me.
This is great. Thanks for sharing your expertise. A lot of good information in there.
Absolutely.
Really appreciate you being a part of it.
Thank you, guys.
All right. If there's nothing else, everybody have a good day. Scott, you got anything else?
Yes, thank you, everybody. Please don't forget to fill out an evaluation and reminder about our education, the symposium coming up in May, and then the state education event on April 23rd. Thank you.
Great. All right. Have a good one, everybody.